late of Ask SAP Live Chat for our first time ever on YouTube, hence the technical difficulties. We're so sorry for the delay. As you're listening to this, the first minute or so of the audio is probably going to be a bit wonky, but rest assured after that, by the time I'm done talking and the people you're really here to see start talking, the audio should be behaving just fine. And we're also having some bad weather here where I'm at in the Bay Area, so hopefully, fingers crossed, that doesn't interrupt the flow of the program like it did during rehearsal. Anyway, we are here to talk about transforming behavioral health care with predictive analytics. As I mentioned in our little promo yesterday, I am very excited about this chat. I love Tech for Good stories, and this one is a really good one. And Hudson Harris from HarrisLogic is joining us today. He's the Chief Engagement Officer, and he and Timo Elliott, SAP's Global Innovation Evangelist, are here to chat with you, and they are awesome. Great guys, great speakers, full of knowledge. So with that, I am going to turn it over to them. But don't forget, if you have questions, please just post them in the comments area. We'll be watching for that. And we will, and Timo and Hudson will answer them for you. Timo, Hudson?
Thanks, Avery, and hello, everybody. Thank you for joining us. I've been looking forward to this because we're going to be talking about improving healthcare, saving lives, and saving a lot of money. So just win-win-win use of better information. So let's start with a longer introduction. So Hudson, please, could you tell us more about your company and yourself?
Yes, Timo, it's a pleasure to see you. Avery, it's nice to see you as well. My name is Hudson Harris. I'm with HarrisLogic. We are a clinical services and behavioral health technology company, and we develop solutions for mental health. Anywhere that we can take technology that it hasn't been before, anywhere that people need a better solution for how to provide care in this arena, that's where we want to go. And everything we do is data-driven and evidence-based.
So how do you, just briefly, how did you get started in this kind of industry? Just sort of you woke up one day and said, hey, we'd like to collect data about mental health.
So we actually, the origin of the company started back in 1982 when our founder started behavioral health services in a few different states. And then fast forward about 17 or 18 years, and he wanted to bring technology to mental health. His background was engineering and thought that it would be a better, a better way to provide the care. So we started developing our own in-house technology solutions then, and it's kind of become something that's taken on its own life.
So we first started talking together about a project you did last year, year before, about helping mental health care patients stay out of jail. Could you tell us more about that project and how it worked?
Yes, so that was really kind of our first attempt, and as far as I'm aware, one of the first attempts to really kind of bring the intelligent enterprise concept to behavioral health and specifically criminal justice. So we, with the support of SAP, took our data from crisis, mental health, paired that with criminal justice data, and mashed it together to create some predictive modeling around what types of markers would help us identify people who needed services and what types of markers might make it more likely for someone to come back. The whole idea being that we want to be able to fine-tune one day what types of services somebody receives in mental health.
So you're sifting through the data and you're looking for the subtle signs that indicate somebody might need a little more prioritized healthcare. So what's the benefit of that? What does the practitioner? So first, what's the profile of the person that's actually using this data, and what does it help them decide to do or not to?
Right. So the people who use our solutions are a lot of times frontline clinicians, behavioral health workers. So I think what the easiest analogy that I can give is kind of if you go to an emergency department with a broken ankle, people know exactly the questions to ask, the tests to perform, what types of medicines you might need, and we're nowhere remotely close to that when it comes to behavioral health. So what we're trying to bring in is the big data aspect to behavioral health. So what does that really look like? So we know that there are evidence-based tools, there are risk calculators that can accurately help a clinician identify how at risk someone is for something like violence or suicide. So now what we're trying to do is take those, embed those directly into technology so that we can start to get big data sets out of that to really understand what's happening with somebody and then how to compare that against population health trends.
So you're making it all sounds a bit abstract. So if I'm a mental health patient and I'm starting to act up, the danger is what? That I end up on the street, that I get arrested?
Yeah. So the areas that we really work in, one of which is criminal justice, one of which is also in emergency departments. The goal of what we're trying to do is keep people out of what we call higher levels of care. So out of inpatient hospital, out of jail. There are some times where those facilities are needed, but a lot of times what we find is that if we really dig into what somebody is going through and really understand what their risk factors are, what their support network is, we can really start to get an accurate picture of what they need to get what the industry calls the least restrictive alternative. So the goal should be to put somebody in the lowest level of care that will provide them with what they need without then escalating them to higher levels of care that they don't need. And that's kind of an important tweak because in most areas of health, physical health, the higher levels of care oftentimes result in better outcomes. So if I have a cold and I go to ICU, it's very unlikely that I'm going to get a cold, a further infection there. It's very unlikely that some of those exacerbating issues can happen. In mental health, that's not always the case. So if I go to inpatient psych, if I go to jail, some of the highest risk periods for suicide and readmission will occur 30 days after discharge. So the goal is to get in before that happens and prevent them from ever getting into those areas so that we don't get those high risk periods.
So basically, you're helping people that might otherwise end up in jail or worse from actually getting into that situation in the first place by alerting the mental health care professionals responsible for that person to intervene and hopefully make sure that everything goes better. So it's just, again, win-win. Now, I've talked to many people about this situation, and I get a couple of remarks almost every time. So the first is, how do you get all of that data? That's got to be super sensitive stuff from all these different systems. How do you manage to do that while respecting all of the rules and governance that must be around it?
Yeah, it's a complicated environment. I think everyone in behavioral health lives in complicated environments, but I think what we've learned is that HIPAA, 42 CFR, those types of privacy-based regulations, criminal justice information systems, also called CJIS, all of those privacy-based regulations are not necessarily designed to inhibit sharing. They're designed to promote sharing with certain protections and guidelines. I think what happens is that a lot of times what we need to do is slow down the discussion, walk through what we're trying to achieve, and then figure out how the rules and regulations support that. For instance, HHS just announced, I think 2 days ago, new guidelines around interoperability and client record sharing, really putting the ownership of someone's privacy record directly on that individual. So if somebody wants to share and it's not, that's a fine, that's a problem. So it's really working through all the different areas, figuring out where the pieces fit, and then getting the legal paper to back it up. So data use agreements, contractual business associate agreements, et cetera. And when you take the time to plug it in, the data can start flowing from a variety of different areas and support the mission.
So basically, you're doing it all right. You're respecting all of the rules. You're making sure that you've got permission from the people concerned. Still, the other question I get is, that sounds a lot like Minority Report, where you're think, oh, this person might commit a crime in the future, so I'm going to intervene now. How would you take that comparison? Is that fair, or?
I would say no. I think one of the misnomers that we have about mental health in the United States is that the people who are going to jail, the people that are going into inpatient facilities, that's where they should be. And I think that's really where we get down to breaking the paradigm around how we provide mental health in the United States. What we do, what we call it is diversions. So if we're in the community and we're with somebody and we're working with them who's having a bad day, our goal is to divert them away from that inpatient or emergency department. That doesn't mean that that's where they should be. It means that where they're best served, not only in terms of their own personal health, but their community around them, is in the community with their providers, with their family. And so what we're seeing in a lot of the mental health arenas for criminal justice is a huge growth of mental health courts, diversion programs aimed at keeping mental health offenders out of jail. And then we're seeing that in emergency departments too. There's a couple of hospitals we've talked to that have developed specifically high utilizer diversion programs where they're working to keep those people out. There's nowhere else a lot of times for those individuals to go if you aren't trying to divert and get them to other resources. So there's a lot of individuals who are going into these areas and going to these facilities that don't need to be. The statistic I like to give is that 2 of the largest psychiatric facilities in the United States are jails. And that's a problem.
Yeah. So it's basically preventative maintenance for mental health care.
I like that.
So just like preventative maintenance for a train or something is about detecting signs before there's a breakdown, it's just a different type of breakdown that we're talking about. Now, we've talked, obviously, the biggest benefit is for the patients themselves. If we can get them the care they need sooner, that sounds fantastic. But I understand that there's other huge benefits that are particularly interesting for your customers.
Yes. So a lot of what we're starting to see is that for behavioral health, there's been some challenges that have kind of persisted over time. One of which has been investment in technology. There hasn't been the drive to invest money into technology and behavioral health. I think that a big part of that was behavioral health providers were left out of meaningful use. And meaningful use, for those of you who don't know, was the program the US government put on to incentivize providers to provide services using an electronic health record that was certified. And then they paid them extra money to do that because the benefits of using that were so large. 6 years, and I think the last count I saw was around $32 billion worth of incentive payments, but none of that went to behavioral health. So we know the benefits of technology and healthcare really well. What we haven't really gotten to is carrying those benefits over to behavioral health. And that's what we're really trying to push, whether it's population health analytics, the ability to have accountability built into the system so you know that the same measurements, the same tests are being done every time. And then on the other end, it's showing that you're doing what you say you're doing. And that's really a key thing that I think will start to kind of change as we go into the next couple of years. It's always been kind of a black box about what was happening sometimes in mental health, but now with technology, we're able to see this is when someone is coming in, this is what's happening, these are the metrics that they're achieving, this is what's happening to them afterwards. Like behavioral health is one of those things where follow-up isn't as persistent as it is when you have a flu or a diagnosis from a medical provider. So all those things are going to start to kind of pull in and give benefits to our clients.
And I understand as well, there's some eye-popping financial benefits for your customers. So your customers are they're the cities that these the health. I mean, who actually buys the software? Who do you make your pitch to about the return on investment from a pure money point of view? Obviously, there's the huge health benefits too.
Yeah. So on the fiscal side, we talk with counties, hospitals. Sometimes, we've talked with schools, crisis lines. It's pretty wide ranging. It's either the people who are providing the service or it's the people who are funding the provision of the service. And that is, it's a wide spectrum though. Sometimes I'm talking with, university administrators. Sometimes I'm talking with county supervisors. It's really a broad swath of people that we talk to.
And how much money have you managed to save people that they could then use for a better treatment for others who need it?
Yeah, so what we're seeing now with some of our solutions is some pretty amazing ROI. I think that speaks a lot more to the low-hanging fruit, if you will. So in criminal justice, we helped a mental health jail diversion program net a 4-to-1 ROI over 4 years that netted almost $30 million worth of cost savings, avoidance, and federal match. And if I had told somebody that those would be the metrics that I could get you out of the jail diversion mental health program, most people probably would have laughed at us, but here we are.
So you're improving people's lives, you're keeping people out of jail, and you're saving cities millions of dollars. It sounds too good to be true. What's the catch?
You have to be willing to get uncomfortable. I mean, I think that's really the thing. We have to be willing to dive into how we build our mental health in our communities. We have to be willing to go through, an ecological assessment to understand where the gaps are. It really, the hardest part is having the conversations where it's like, it doesn't matter what happened. What matters is how we improve the quality of care that we're giving to people. And then getting people that want to support the data use, that want to support the use of all this incredibly rich data in a way that's fast, secure, and gives people the information they need right when they need it.
Sounds like a lot of technology and innovation is that there's big return on investment available, but as ever, it takes a lot of hard work and people and process and organization to actually adapt things to be able to use that technology in the best possible way. So let me, we've already got some questions on the call. People are interested in how exactly you did this. So can we touch a little bit on the technology? What technology did you use? Just at a high level for people on the call, there was a specific question about, is this a custom-made neural network, or is this an API in the marketplace, or how did you go about actually doing this from a technical point of view?
So everything that we built was scratch our own itch. So we developed solutions to support us in the clinical services we were providing. So on the crisis side, we became an American Association of Suicidology accredited crisis center in 2008. We provide 24/7 mobile crisis and integrated hotline services to that area. And we wanted to develop a platform to support that. So in 2008, we launched our what we call Stella Crisis, and it's a purpose-built platform that has evidence-based tools built in, guided documentation, and analytics to support crisis organizations working to save lives. So now it's used in the field for suicide prevention, and it's used for mobile crisis outreach. And then we also have now worked to take that and bring it into our mental health jail diversion program that we're also helping support technically and clinically in Dallas. So in Dallas, we developed a solution to first help identify the individuals who were coming into the system with mental health conditions. And so what we see nationally is it can take a couple of weeks to identify somebody with a mental health condition in criminal justice. So we needed a solution that would help us identify those people rapidly and then notify the right people. So what we did is we built a platform that integrates multiple data streams, so criminal justice, jail, court, behavioral health, encounters, Medicaid data, a whole host of data, with the goal that when somebody comes to jail, we can identify them as quickly as possible. Going back to the earlier part of our conversation, if somebody goes into jail and spends time there, their odds of coming back within 6 months are as high as 67%. So that rapid identification is key. So we developed a platform that would integrate data, provide live alerts, and then from there, we're now doing our evaluations for mental health jail diversion using Stella Crisis to get that evidence-based version of what does somebody need? What is the level of care that they need so that we can get them to their least restrictive alternative, which a lot of times is not jail.
Great. And the predictive technology, I understand, came from SAP, and you had a help from a partner?
Yes, it's very exciting. So it was 2 years ago, we worked with EV Technologies and SAP. SAP had an innovation grant at the time, and they challenged us to see whether or not we could predict someone's likelihood to return within a certain period of time. And so working with SAP and EV Tech, we developed a pilot predictive algorithm around what are the hallmarks of the individuals who are coming in and need more intensive services. What are the people who need less services. So what's the likelihood to return? And that led to some pretty amazing results, and we were able to happily win the 2018 Innovation Award for SAP on digital transformation.
Congratulations again. And how good are those predictions? What, do you have a problem with false positives, for example? That's another question I sometimes get.
Yeah, the challenge around this is that the data is always changing and adding. So we're always adding in more. When we did the predictive pilot, we took 36 months of data and then built the model in the first 30 months. And we had to, we stripped out a lot of the things that could create problems, potential bias. What we were able to determine was that we could identify those individuals who were not likely to return with a 99% degree of accuracy. So that means that we can say this individual is not likely to return and would be accurate 99% of the time. On the other side of that, we were 72% accurate on who would return in a certain amount of time. And so what that does is that gives providers and people the ability to say, this is how we tweak and understand what intensive level of services somebody needs, because right now, mental health in a lot of the public sectors is a fire hose. Here's all the appointments, here's your brochures, here's your medications, and then everyone kind of gets the same. The whole idea that we're trying to push with that pilot was, could we conceptually develop tailored, supported by data, tailored care plans? And that's kind of what we're working on starting.
So really, it's about the customer experience and being tailored for an individual. It's just in this case, we're talking about mental health issues rather than a stay in a hotel or something.
Exactly.
So, and also for the medical health professionals, it sounds like before they had 100 dossier people files they could look at. You've already narrowed it down to here's the 1% of all of that you should take a look at first before you look at the others.
Yeah, I think what we've been able to do, kind of even in front of that is throughput, and I think that's something that business is really good at, and that's something that SAP is really good at. How do we maximize resources? How do we maximize throughput and flow? Prior to us, there was a certain amount of people that you could evaluate and find. It can take a clinician, like I said, a couple of weeks to find someone. With the technology we developed to support it, it was about a 5-time multiplier of the number of people that could be identified, evaluated, and seen. So on the front end, you're able to see. And then in the system, once somebody is being evaluated, we're able to get much more accurate care plan creation, because then we can come in and using those risk scores, using those tests and those formulations, understand what somebody is at risk for. So ultimately, predictive analytics will be able to support all of that. Once we get the opportunity to kind of build that directly into some of these things, you'll start to see that as these scores are filling out and working together, the analytics will start to support that quicker and quicker and quicker.
So efficiency and productivity and throughput, so basically doing more with less. So using the scarce resources to help more people faster.
Necessity is the mother of invention.
Sounds too good to be true. Now, my understanding is that given this original program, you're now moving to a whole new era using the same kinds of concepts. So tell us more about that.
Yes. So last year, last year we submitted a grant to the National Institutes of Health to embed the zero suicide technology zero suicide framework directly into our technology. As part of that, we started talking and working with the Zero Suicide Institute and developed a partnership even before that grant was going to start to say, let's start working together now to build a zero suicide platform. For those of you not familiar with zero suicide, I strongly suggest you go look into it and read it. I can provide a link in chat later, but it's an incredible resource that is actually geared towards bringing suicides to zero. And so what that looks like is there's 5 different buckets that go into zero suicide: identify, engage, lead, transition, and improve. Each one of those buckets comes with specific things to do, specific training, specific methodology, clinical pathways, et cetera. So what we're working with the Zero Suicide Institute to do is take that and build that directly into our technology. Because right now, while zero suicide works, it needs that next leap forward in terms of tech to make it a lot easier. So we're hard at work with them on making that happen.
When we were discussing earlier, you gave me some figures about the dangers of suicide today. That it's the number.
Yeah, it's the number two. Suicide is the number two leading cause of death for college students. And then I think for K through 12, I believe it's third. And I think everybody has seen the statistics from the World Health Organization and from the CDC that all of those rates are on the rise. We're seeing across the board mental health incidents go up, mental health service consumption go up, and then a lot of the rates around those conditions are going up as well. What's particularly sad is that the incidents for psychiatrists are going down. The number is going down. And you're seeing a lot of the mental health services get lesser funded in some communities. So we have a disequilibration where we have to try and figure out how to do more with less, and then put the power into the hands of the people providing those services to help them really maximize what they're doing.
So technology is a possible, not solution, because technology never solves anything on its own, but technology can help enable this process of reducing the number of suicides. So is it a similar framework that as you talked about, where you're collecting data from different sources? What are the different sources in this case?
You know, in the zero suicide case, in a perfect world, we would be able to pull in healthcare data, contextual data analytics. I mean, really, there's so much we don't know about what the data can tell us when it comes to suicide and mental health that it's hard to even say what we want, because at a certain point, we want as much as we possibly can. We want to have as much data as we can to try and figure out what's happening and when it's happening. The research does show that, you know, intervening early, promoting help seeking, encouraging hope, all of those things are really helpful. And so how do we use technology to support that? On the clinical side, we call it clinical decision support. So, you know, the human brain has the ability to hold 5 or 6 things in active memory at any time. Take a look at one severe suicide crisis call, and that call could span 2, 3, or 4 hours, depending upon the situation. It's really hard to hold all those things in active memory about what you need to know about what's happened. So some of the things that we're doing are creating processes in the software that will float the correct information to the top, that will create, you know, synopses of a particular episode to help the clinician do what they really do best, which is talk to the individual, have that therapeutic relationship, have that ability to engage and talk, and not have to be distracted or worried about, well, did I remember what they said here? What was their risk factors over here? What was the scores here? So part of what we're trying to do is kind of redesign that process so that the clinicians have what they need, and really the technology gets out of the way. It should really just be live support.
Okay, so I was imagining something like a college or a university with opt-in, where people could say, you know, as they sign up for the college, would you be interested in taking part of this program? And then you'd take in, as the universities already do, they already know a lot about students. You could potentially mine that data for this side of things and hopefully save some lives. But you're saying it's also part of the actual process of, if somebody self-identifies, then it's about using all of the data that comes in that process to optimize it, again, to throughput, efficiency, and better care.
Yeah,
that's fantastic.
Yeah, we're working with a university right now who's a leader in mental health, and what we've developed and are hoping to launch and go forward with would be taking our software and deploying it at universities across the country. So a lot of universities struggle with the same things that healthcare does around the world. Is somebody going to their appointments? Does a caseworker know if somebody went to an emergency department? Did they miss their psych? Did their behaviors change? Did their activities change? Have they stopped doing some of the things that they do? Individuals in universities today are digital natives. Their privacy constraints are very different conceptually than what ours are. I mean, even just a generation or two prior. So working with those students on consent-based mental health care means that we're able to figure out what's happening to students if they do miss an appointment, or if they do go to the emergency department. Somebody should know. Somebody should be able to say to their parents, "We did know that this happened." Somebody should be able to say to their RA, "Hey, this person hasn't come in a while, or we haven't seen this individual. So part of what we're trying to do is use already existing data structures. So the SAP Student Activity Hub is a really good example. Captures a wide array of data about students. We want to pull that data in and say, if we take mental health and physical health and all the student activity, what does that tell us about a student in terms of what they need? Because I think at the end of the day, a lot of this comes down to a needs-based assessment. You have usage of college mental health resources across the country are skyrocketing. They're in some places they're quintuple where they were even as short as 3 or 4 years ago. That's not a trend that's really going to stop. If anything, it's probably going to continue to rise. So it's how do we use technology to start to take that data and really create actionable intel that can help prevent a crisis.
We get some questions in the thread, so thank you for folks asking questions. Again, on the technical side, do you know more about, is it SAP Predictive Analytics 2.0, and where do you host the models? Is it on-premise? Is it on the cloud? Is it part of the SAP Leonardo framework?
Yes, so I don't know if it's 2.0 or not. That's not actually one I'm familiar with, but we hosted it in AWS. That's where we did our predictive pilot. And we are, let's see, yeah, so AWS, and then I'm not exactly sure on the Leo Foundry. I know that the pieces in the data analytics that we use are a part of Leonardo. I've talked and given things about that, but I'm not necessarily the techie person. I'm more of this person.
And just for folks who do have more technical questions, there is a more detailed technical podcast that was done for the diversion project for sure. evtech.com, I think it is, would have that podcast. So the Leonardo Machine Learning Foundation is more of the TensorFlow framework using machine learning along those lines. And I don't think you're using that. I think you're using the more structured machine learning from SAP Predictive Analytics. I think one of the advantages of that for you, correct me if I'm wrong, is that you have a certain amount of more transparency about the model, because I'm guessing that a full black box might cause problems. Because
that's when you get into Minority Report.
Right.
It has to be obvious, it has to be patent, and it has to be supported by science. So we took that predictive model, and we have it with a researcher right now who's vetting the data and the modeling from a research perspective to publish, because it's not enough to find an analytic that says something. You have to be able to demonstrate why that analytic is accurate, and then why it is supported by research and not creating, biases or other problems. So when we built the model, there was an option to just say, here's a percentage. And we opted for a much different route. We went for the live percentages, but then what the leading factors were that supported those percentages. Because at the end of the day, our goal, again, is to support the decision-making, not make the decision. The goal should be that the clinician who doesn't have the time to do a billion computations in their head around predictive analytics can look at something and understand, okay, these are the things that are going into that and what that means.
So just for people who are watching, the SAP Predictive Analytics is machine learning in the way that it's automated forms of the kinds of statistics that you learned at school. The advantage is that the rules can be easily opened out. You can find out what the key factors are. You can dig into why or how the model is created, so you have a lot more visibility, and you can do a lot more checking to see if variables are being used that make sense. So that's we're often seeing a lot of this as algorithms become more important. People understandably want to understand what's going on behind the scenes in order to be able to know whether they can trust it or not. And the downside of some of the neural network approaches is that you can't really unpick them. It's a black box. So we're seeing a lot of people very interested in these more automated forms of the statistics that we use in SAP Predictive Analytics because of the transparency and hence the ongoing trust. So actually, though, I do have a question, though, about ethics and governance. So obviously, you've touched on what you need to be able to do. So, but how do you actually approach that? I've been recommending to organizations that they need to have professionals. So at SAP, we actually formed an ethics council. As we're embedding machine learning into everything we do, we have a council inside the company, but then also an external council of experts in ethics and professors and so on, who help guide us to make sure that we're not messing up because we're not ethicists.
Right.
How do you approach that?
It's interesting you said it. So we actually met one of those committees and talked with them about what we do in criminal justice, and we developed a brief around everything that encompasses the work that we do in the criminal justice system, how it works, the models behind it, the support. And that is exactly the type of rigor that we need to apply to these types of things. Without those ethics, without the data governance, it's like giving somebody a car with no gas, because it's really easy to just do all the things and make it happen. It's a lot harder and a lot more important to do it right from the beginning. So everything that we've designed is built on privacy by design principles, so that we're really driving to embrace privacy and to ensure that people have the rights that they want. And what we found is over time that the more people have used our systems, the more there's been a willingness to share and more been a willingness to participate and be a part of it. The ethics issue is something that I think is going to continue to come up. And I think you pointed out some really good information there about the neural networks and how that's a black box. Going back to that, one of my most favorite memories of that project is sitting live, watching all of our data, watching the native HANA analytics start to pull out some of the information we were looking for, and being able to say, well, what if we categorized it this way? Or what if we pulled it this way? And then watching the models change and tweak live as we went. It's such a different experience than other times where it's been like, I would like to know this, and here's my data. And then 2 weeks later, somebody comes back and says, here's what it is. I think the more we have people involved from an ethics perspective, and then techno-ethicists, I don't know if that's a word, but let's go with it, that are a part of those discussions from the beginning. Something that we did from the very beginning was clinician paired development. So our developers sit with clinicians and talk through what are they going through, what's happening, and that creates a much different customer experience or user experience than a technical program being developed, in a dark room. I think what we'll start to see as an industry is the growing role of the privacy officer also becoming some of the ethics role. The concept of a techno-ethicist, I can't remember, however it's said, actually being in these meetings with the technology developers. Because I think what we've learned from a lot of the recent problems is that if you don't involve that from the beginning, it's a lot harder to bolt it on afterwards. So you want to have the privacy in at the front, as opposed to trying to figure it out at the end.
So okay, going back to your analogy, you said it was a car without gas. I would go with a car without brakes. You can go fast, but or giving a motorcycle, a 600cc motorcycle to a 16-year-old or something. Right. It's like without training. It's like, well, yeah, they could go really fast, but you probably want to make sure that you have some guidelines in place. Now, we discussed earlier, there are some new opportunities as part of the SAP HANA platform. Notably, the ability to embed algorithms to do differential privacy. So tell us why that is of interest to you and what it is.
Yes, privacy is the passion of mine. On my background, I'm an attorney. Please don't hold it against me, but I am still licensed to practice law. And I did a lot of work in privacy and HIPAA. I wrote and talked with a bunch of people in the EU about GDPR as it was coming out. And so privacy is something that's near and dear to my heart. And I've always believed that data anonymization through K-anonymity and differential privacy are really the only ways we're going to take that big leap forward. And so at Sapphire last year, we got to meet with Stefan Kessler, Alex, and some people from the SAP labs that are working on this data anonymization tool. And so here we are now 9 months later, and we're working with Stefan and Alex and Rosie and several people from there to take this tool that HANA has that they developed, be able to take really sensitive data, arguably the most sensitive possible data you have about people, pass it through this tool, and then create tables that do not identify anybody, that can meet safe harbor for HIPAA, that can satisfy GDPR requirements, and create tables that are then actionable, that are rooted in real data, but mask any chance of identity or figuring out who people are. We are in our POC right now to demonstrate the value of that, and specifically to demonstrate the value of that in what we do, which is mental health and crisis care. So we're working with SAP right now on developing models to figure out who's most likely to connect to outpatient providers after going to the hospital, who's most likely to connect to outpatient providers after having a crisis event. These things seem basic, but they are bread and butter for what we need in the industry to try and move the needle. And so the anonymization tool with our data is going to demonstrate the value of that you could then take to a hospital and say, hey, you can anonymize your data, match it up with other data sets, and then create some really incredible magic without having to run afoul of HIPAA or GDPR or any of the other data sets. It's, if you know, I hate to make really broad predictions, but it could be an absolute game changer for the industry, healthcare and mental health, not to mention business as well, to be able to start working with this data that's honestly previously somewhat unusable. A lot of organizations won't share, and they're protecting their people's privacy. Some of those regulations and guidelines are changing to require sharing and just pushing people's records out if they want to. But what we needed was a technological tool to solve something we couldn't. And I think that's what data anonymization is going to be.
It's always struck me that one of the things about healthcare data in particular is that the privacy of that data is absolutely essential. And yet, at the same time, the ability to analyze that data in aggregate is absolutely essential as well, because that's what we can use to save lives. So reconciling those two things has been hard. These kinds of tools that are all about de-identification are a huge step forward. I use de-identification because, having talked to a couple of privacy specialists, they really felt that privacy was quite a loaded word and this complex process. So we should emphasize this is from a technology point of view, this is a de-identification technology live in HANA. And that's part of your overall privacy process. But as you say, a fantastic opportunity. All right, we have a few minutes left. So in a minute, I'm going to ask you about like future opportunities. But we can touch on a new, I believe you're working with SAP on a plan around suicide.
Yes. It has not been released yet, but in line with what we're doing with the proof of concept, we're working with SAP around how to start to invest and change the game for how mental health and suicide awareness is handled now everywhere. Several months ago, we started working with SAP Global Media, and we are part of a media campaign that's going to be coming out for suicide awareness, suicide prevention. There's going to be social media, a video, some articles you'll see in some major publications, and that's going to be released in North America, Europe, and Brazil. And it's really heartening. It's really exciting to see an organization like SAP get behind something like this, and really see the desire to invest and move the needle forward to try and say, how do we actually start to take all of this amazing knowledge and technology that has made business bigger than ever before and save lives? How do we actually take that technology and those experiences to bring it down to the micro level of making sure that somebody gets the care that they need to be here with us for a very long time?
It sounds fantastic. So you heard it here first, folks. SAP stands for Suicide Awareness and Prevention. Again, I'm going to talk about the futures, but one question, just for you personally, you said you're a lawyer working on privacy. How did you end up in your role now? And other people on the call are maybe thinking like, well, you know, I have a certain number of skills. How can I use that in a way that makes impact on people's lives as Hudson is doing? Any advice, thoughts?
Yeah, it's not hard to get involved in mental health. I think what we're seeing today is that the volunteers at National Suicide Prevention Lifeline text crisis, and we'll put some links and some phone numbers into chat. They take volunteers. The text line, you can literally sign up, and then you can be there when somebody reaches out to say, I need help. You receive the training you need, and then you can text back with people. You can go volunteer at call centers. There's organizations all over the country I'd be happy to plug anybody into. DM me on Twitter or find me or email me. I work with organizations coast to coast who would love everybody's help. If you don't have time, donate. Push money into organizations like American Association of Suicidology. Push money into organizations that are researching this disease. If you look at the money that went into suicide prevention compared to other diseases, it's far too little and far too small. So it's time, it's resources. And then here's probably one of the most important things that anybody here can do if you're listening today. Reach out and talk to people. Ask, are you okay? Be okay having the uncomfortable discussions with your friends about, is everything going okay? Because the research shows that ability to reach out and say hello to somebody, to connect to somebody, to find out if they're okay and be there and just listen is huge. So small all the way up to big, the opportunities to help change how we do mental health is there.
That's fantastic. All right, final question. Crystal ball, where's this going in the future? What's your dream?
I mean, what I'd like to say is my dream is zero suicides. I think that's what we're all working towards. But I think that's something that we're working towards and something that we're going to have to build on as we come. I think the year by year thing that we're going to see is an absolute explosion of technology into mental health. We're getting, there was a bill passed not long ago that authorized pilots to bring behavioral health providers into meaningful use. So I think what we're going to see over the next year or two is an absolute revolution, renaissance, whatever you want to call it. Mental health is going to blossom, and we're going to start to see it go the other direction with the benefit of technology, evidence-based care, and the hard efforts of all the clinicians and people working the crisis lines have been working so hard for so long for.
Well, fantastic. Look, Hudson, this has been just fantastic. So it's great to hear about how technology and data and good people like yourself are working together to help improve health, save lives, and save a lot of money that can be used to help others that need it. So it's been great talking with you, and thank you again.
It's a pleasure.
Yes, thank you, both of you. The comments, there was lots of comments throughout the chat. Everyone loved the information you were sharing, so thank you. One last quick question that came in. Jolie wants to know, is there a timeline for your new campaign initiative on when it might be coming out? Is that something you can share, or is that top secret?
No. So we are supposed to, let's see, today is the 13th, so we're supposed to show the video at HIMSS first. And then I believe the release, if you will, with the social media campaign, the articles, etc., will come on the week of the 18th. And then I know SAP is working hard on how to expand that reach, and we're already getting a lot of outreach from people at SAP on how they can help expand. So probably going to kick off on the 18th, I believe.
That's great. Again, thank you very much. Thank you for everyone who participated. We hope you like our new home on YouTube as much as we do. And until next month, what a tongue, I'm on my own tongue. That's live for you. But until next month, have a great day, great evening, wherever you're joining us from.
Thank you.